Okay, so let's get into this clinical vignette. It's definitely designed to make you think. We've got a 72-year-old patient.
Right?
Now, they have a history of rheumatoid arthritis, RA, and they're on adalimumab for that, also Crohn's disease, and they had an ileostomy about 6 months ago.
Right. So complex history there.
Definitely. And they come in with this really painful ulceration right around the stoma. It's been there a while, and nothing has worked. They've tried changing the ostomy appliance multiple times, even used high-potency topical steroids. No luck.
Refractory.
Yeah.
That's key.
Yeah. And when you look at it, it's a 3-centimeter ulcer. The description is crucial. Sharply demarcated, violaceous, sort of purplish and deeply undermined border. Like the edge is sort of eroded underneath.
Okay. Violaceous and undermined. Got it.
And importantly, the stoma appliance itself. It's checked, it fits perfectly, no leakage. So that rules out some basic mechanical issues.
Right.
So what's the most likely diagnosis here? Let's run through the options. A, allergic contact dermatitis to the flange. B, irritant contact dermatitis, maybe from leakage. C, Pyoderma gangrenosum. D, a pressure ulcer from a bad fit. Or E, could it be the Crohn's disease coming back locally?
Okay, this is where connecting the dots becomes really important. You've got, I'd say, 3 really strong clues pointing you in the right direction. First, like you said, the systemic history. Crohn's disease, RA, these are inflammatory conditions known to associate with certain skin problems. That's a big flag.
Right.
Second, it's refractory. It didn't get better with the usual stuff, good stomach care, strong steroid creams. That makes things like simple irritant or allergic dermatitis or even a pressure ulcer from a poor fit much less likely, especially since we know the fit is good.
Okay, so that helps narrow it down.
Big time. But the absolute most important clue, the real giveaway, is the morphology you described. That specific look, painful, violaceous, and that deeply undermined border. That description is almost, well, it's practically pathognomonic for one condition.
Pathognomonic, meaning it's a sign so characteristic that it points directly to one specific disease.
Exactly. So based on all that, particularly that border, the correct answer is C, Pyoderma gangrenosum.
Pyoderma gangrenosum, or PG. Okay, so we've nailed the diagnosis based largely on that distinctive border. But let's dig into why that border is so specific. I mean, some people might think, okay, Crohn's disease, inflammation near the stoma, but maybe it's just the Crohn's flaring up there. Option E, how is PG different?
Yeah, that's a really common thought process and a critical distinction to make. Recurrent Crohn's disease at a stomacyte can happen, but it usually looks different. It might be more like deep fissures or sort of cobblestoning, maybe more irregular ulcers. It typically lacks that very specific, smooth, raised, almost rolled, purplish, undermined edge you see in PG.
Okay.
See, PG isn't directly Crohn's disease in the skin. It's its own thing, a neutrophilic dermatosis. Which sounds complicated, but it basically means it's caused by neutrophils, a type of white blood cell, flooding into the skin and causing damage inappropriately. It's an inflammatory overreaction.
And the name is weird too, right? Pyoderma gangrenosum sounds infectious or like tissue death.
Totally misleading. It's a historical name that's stuck. It's not caused by bacteria PO, and it's not true gangrene. It's a sterile inflammatory ulcer.
Fascinating. So,
Yeah.
okay, the location, why the stoma site? Is that just coincidence?
No, not at all. That links directly to this concept called pathergy.
Pathergy.
Pathergy is basically where minor trauma, like even a needle stick, or in this case, the minor constant irritation and pressure around a surgical stoma, can trigger a new PG lesion to pop up in someone who's susceptible.
So the stoma site itself, the trauma of its creation and presence, is the trigger.
Exactly. It's a classic site for pathergy-induced PG, especially in patients who already have underlying conditions like IBD or RA.
Okay, this really changes how you think about managing it, because this patient, they're already on adalimumab, a pretty strong biologic, for their Crohn's and RA. So why did they still develop PG, and what do you do next?
That is the absolute core point here. Recognizing PG means realizing this isn't just a local wound care issue, something the stomators can fix with a different appliance or cream.
Right, it's systemic.
It's a manifestation of systemic inflammation that's either broken through their current therapy, the adalimumab isn't fully controlling this particular inflammatory pathway, or it's just a particularly aggressive case. So management has to be systemic too.
Meaning more than just topicals.
Way more. You usually need to escalate systemic immunosuppression. Often that means starting high-dose systemic corticosteroids, like prednisone. That's often the first line for active PG. Or sometimes you might add another agent, like cyclosporine, something that hits the immune system differently.
Even though they're already on a biologic.
Yeah, sometimes you need to optimize the current treatment, maybe adjust the dose or add something else on top, or even switch biologics entirely. Research has shown that delaying this kind of aggressive systemic treatment can lead to really rapid and devastating tissue destruction. You have to act fast.
Wow. So recognizing that border basically shifts the whole treatment plan from local wound care to systemic immunosuppression.
Precisely.
Now, one thing that stands out, you said PG is often a clinical diagnosis based on that classic look, but research often mentions biopsies being done.
That's true. A biopsy is often performed, but usually not to confirm PG because the histology isn't always specific. It's more often done to rule out other things that can look similar, like infections, maybe weird cancer, or vasculitis.
Okay, that makes sense.
But that brings up a really interesting clinical pearl, something for you to think about. Knowing what we just discussed about pathergy,
Ah.
why might a doctor be, let's say, quite hesitant to actually do that biopsy on a suspected PG lesion, even if it's technically recommended to rule out mimics?
Because the biopsy itself is trauma
Exactly.
and could potentially make the PG worse or cause a new lesion at the biopsy site.
You got it. It's a real clinical dilemma sometimes.
Okay, so let's wrap this up. A quick summary. If you see a patient, especially one with known IBD or RA, who has a painful ulcer near their stoma that just isn't healing despite good local care, and the stoma appliance fit is perfect, you absolutely need to look closely at the border. If you see that classic violaceous, purplish, deeply undermined edge,
Think PG.
think Pyoderma gangrenosum.
Well,
And know that the next step is likely systemic treatment, not just more creams or different bandages.
that's the key takeaway, recognizing that morphology changes everything.